Welcome to the last session of MD Expo Dallas. My name is Dave Scott. I work at UCHealth in Aurora, Colorado, and I've been doing these MD Expos for quite a while. I think it's since 2015 is when I started doing MD Expo. And this presentation is intended for, I kind of have like an echo. Move over. It's probably coming off the speaker, maybe, I don't know. I wanted to look at that computer so I didn't have to read the screen, but now I got to read the screen. I've been doing these MD Expos for about 10 years. I've done a lot with the Colorado BMET Association in the past. I'm kind of known for starting the CBET review that CBET did for a long time. CBET is the Colorado Association of BMETs. And now I do that same CBET for AMI. It's the same CBET review. We're very similar to what it was in CBET. I still seem like I'm getting an echo, but too close. Okay, that's better, I think. Is it better? Could you guys hear the echo too? Maybe I can stand back over here. I probably had it, yeah, I probably had it too close. Yeah, that's better. Yeah, I can go back and forth. Sorry. I think it's good now, doesn't it? Okay. So it doesn't move around. Okay. All right. Thanks, Dave. So that's a little bit about me. I've been doing this a long time. This presentation was intended for people that are kind of new to biomed, maybe not have done as much troubleshooting on vital signs monitors or even know what vital signs are. So that's kind of the level that it's meant for. It's meant for new people in biomed. This is my third time doing this presentation. First time at MD Expo. First time was at the Biomed Association as a practice run. And then I did it for our shop as another practice run. And I like to practice stuff like that, kind of smaller scale if I get a chance to. I don't always get a chance to do that on all the presentations I do, but whenever I get a chance to do that, I always take advantage of it. So what are vital signs? Vital signs are a measure of body functions, which include respiratory rate, body temperature, pulse ox, or pulse rate, blood pressure, and oxygen saturation. These are indicators for assessing a patient's health status and can be based on age, activity level, or they can change based on age, activity level, and overall health. So the first one, I took the easiest one first. Oh, I guess I'm not quite there. These measurements are taken by clinicians to assess a patient's well-being. I think it's funny, this presentation by itself, this assess, when I did it to CBET, I misspelled assess. So you can imagine what I spelled it as. I didn't put an S. It was asses. Boy, I've heard it. I see CBET people that were here, and I've heard it several times from them. And I always tell people, like, the hardest presentations that I do are not always here at MD Expo. Sometimes they're the local ones because I see those people all the time, and they never forget when I screw up, like that, like assess. So I get kidded about that all the time now, that I've done that once and messed up it, but it didn't get underlined because I spelled it correctly, but I just didn't realize I didn't spell it right. I didn't know. So these are taken in clinics, emergency department, screening areas, and inpatient floors. I mean, you've probably seen this a lot on monitors in patient floors. A patient's direction of care is based on the vital signs. It's important for these readings to be accurate. That's where we come in. That's our job. So the first one is one of the easiest ones. It's respiratory rate, at least the easiest if it's done manually. So manually is a timer and visually, so they just watch and see how many breaths per minute the patient is taking. Normal is around 12 to 20 respirations or breaths per minute. Respirations can increase with fever, illness, and other medications or other medical conditions. And it also can be taken off of lead 2. So who knows what lead 2 is? Take a deep breath. Let it out. Where does that come from? What's expanding when you take that deep breath? Your chest? So what lead goes from here to here? Across your chest. Right arm to left leg is lead 2. And I always remember by the number of L's. That's kind of one of my certification review stuff that I talk about. But as you expand, as your chest rises and drops, it's a change in impedance. And that monitor measures the impedance change, and that's interpreted as breaths per minute. That's where on the monitor, that's where that comes up at, is your breaths per minute on the monitor. Your respiration rate is off of ECG lead 2. So if it is ECG lead 2, if done visually, there's really nothing to troubleshoot. If it's through ECG lead 2, then I always say to start with the patient, electrodes that are attached to the patient, and kind of work your way back to the monitor. As usually the monitor is the least amount of the problems. It's not usually going to cause a bad respiration rate. ECG lead 2 is right arm to left leg, like we talked about, and it's the white lead and the red lead for the colors. And like I said, I have a whole presentation on just ECG stuff. I'm not going to get into all that here, but it's kind of something that as a beginning tech, you should at least know some of this. ECG lead 2 looks at impedance change, like I was talking about with the breath, the big breath in and the breath out. If the electrodes are making good contact, it could be, if the electrodes are not making a good contact, it could equal a bad respiratory rate. So defective ECG cable, like the trunk cable. And then if possible, I always put it on your simulator. So you have a known good signal. So you're not questioning the patient's signal. It's a known good source for the signal. If you can attach your ECG leads to your simulator, it's always the best to do it that way. But work your way from the patient, including electrodes. Sometimes I've been in many times they said, like, when's the last time you changed the electrodes on the patient? Oh, we just did that. It's always the story that we just did that. And can you do it again for me? Because I didn't see, and can you put those? And sometimes you want to check the date on the electrodes. If it's something that's already been open, they can dry out over time. So if it's a pack that's already been open for a while, once it's open, it has an expiration date. And usually you'll see like a tear on the packet, and it says like how many days after, like by the tear part. And usually they should write the date on the pack that it's opened. Like when they opened it, like if it was today, it'd be 11/12, and then it's usually 7 days from. And probably where we live in Colorado, it could dry out even faster because it's no humidity there, and maybe a little more humid here in Dallas, but they dry out fast. So if they replace it with a pack of electrodes that's already been opened and they put it on the patient again, say, can you use a new pack, or can I hook it to my simulator? That's always the best bet. Next vital sign is body temperature. This one has a lot of different ways of measuring it. Normal body temperature, we use mostly the metric system in medical. So it's 36.5 to 37.2 is considered a normal body temperature. And this can be measured orally, thermistor-based temperature measurement, and it goes to a display. Have you ever heard of a thermistor? Thermistor, what does thermistor do? Anybody? Nobody? It changes resistance with temperature, right? So if there's a temperature, it affects the resistance on that thermistor. Most thermistors are at negative temperature coefficient, which means the hotter the temperature, the less resistance. Temperature goes up, resistance goes down. There's negative temperature coefficient. So that's how most thermistors work. And they can be easily damaged by dropping. We'll see that when I have a little bit of troubleshooting on each one of these vital signs. And I said this is intended for people that are new to the field, but I've been working in biomed quite a while, a long time. You can tell I'm kind of old. My beard's all gray and I have no hair on the top. But some of the stuff I have in here was actually new to me when I did this presentation. I study for these presentations and put this all stuff together. Some of it I already know because I've worked in it so much, but other stuff is like, oh, I didn't know that, and I want to put that in there just so other people know the same thing. But Thermistor has been around forever. Rectally is the same as orally. It's thermistor based. Rectal thermometer temperatures are not done as much because they're so invasive, but it's like kind of a last resort of taking temperatures on patients. And you always know the biomed joke about how do you tell the oral temperature or oral thermometer from the rectal thermometer? The taste? The red one is the rectal thermometer and the blue one is the oral thermometer. Old biomed joke. Old like me. So axillary is under the arm. It's usually slightly lower than the oral temp. The rectal temp is usually a little bit higher than oral temp, but it's same technology as oral. When I used to work at a children's hospital in Colorado, and we did, it was called a Tempodot, and it went on like our babies, our newborn babies. Whoops, if I cover that, it makes too much noise. It went on our newborn babies in our newborn ICU, and they put this Tempodot thing. It was kind of like those temperature things on a fish tank, where it changes the color of it, kind of like a mood ring, kind of, I think is, but it would actually read very accurately, surprisingly, but they would leave it under the baby's arm for 2 minutes and read axillary, the baby's temperature. And then last resort was rectal temp on the babies if that didn't work. But that's kind of a lot, like I said, a lot more invasive, especially on a baby because they're so small. They always wanted to do axillary temperature on them if they could. They can't do oral because the baby spits out the oral. And then now, it's like the skin temperature is pretty accurate. Ear temperature, infrared sensor it uses, kind of the same as like the infrared things you could take temperatures with. Maybe you've seen like the engineering people check the airflow out of the air duct and they just point it and shoot it and it does the infrared temperature. Same kind of technology, infrared sensor. Measures tympanic membrane. Many have equivalents of other temps. So the tympanic thermometer usually has an oral equivalent, a rectal equivalent, and then one that they call core temperature equivalent. The core is usually the highest. It's kind of based on your body, like your central body core temperature. The infrared sensor works on something called emissivity. Has anyone ever heard of emissivity? You ever seen those drawing or like pictures of something where the hottest part is really red and then it kind of goes out from there? The hot, like that's emissivity. That's the heat that it's emitting, and the hottest part is that red color, and then out from there it's the less temperature. And that's kind of what this ear thermometer works on. And if you think about like your tympanic membrane, like think my tympanic membrane's right here. How far is that from my heart? It's not very far. So the blood doesn't travel very far. So it stays about the same temperature, pretty close to what core temperature is and heart temperature, like the main body temperature. Skin thermometer, infrared sensor, very similar to ear measurement, except for that's the one they can do it temporal, which is the one that kind of scans across and then behind your ear. I'm trying to think of the name of the ones, and I have a picture of one coming up in just a second. I can't think of it. We use them at my work, and I can't think of the name of it now. But that's works on temporal and emissivity that I was just talking about. Hypothermia. So what's hypo? What does that mean? Low, and hyper is high, right? So some of these terminology, I kind of try to throw some terminology in if I can. I feel like the certification test, which I teach the review for, it's kind of moving away from A&P stuff as much and electronics. But I feel like in biomed, we kind of need to know some of the A&P stuff just to be able to talk with staff. So if they tell you hypothermia or hyperthermia, or can I get the hyperthermia unit, which is the one that circulates the hot water, that's hyperthermia unit. So we're talking about hypo is anything less than 35 degrees C or 95 degrees Fahrenheit. So very low body temperature, which we'll see a slide about on troubleshooting about that. Orally, thermistor base, most commonly, this is troubleshooting for body temperature. So thermistor base, most commonly it's dropped or damaged from dropping. And then it has usually a cable that connects to the main box. The cables get damaged and the connectors get damaged. That's usually the most common, or they drop the entire box and it breaks. I know no one ever drops equipment in the hospital, but somehow it magically happens, but no one did it. Rectally and axillary, they use the same type of thermometer, except for the probes are a different color like we talked about. Ear thermometer, or the tympanic thermometer, is infrared sensor. The lens gets dirty and they also get dropped. And then skin temperature, infrared sensor, same as above, but the ones like that you saw during COVID, where they do the temperature on the forehead, or they have the one that they just point at your forehead, or maybe you stand in front of a machine and it read your temperature. That was looking at emissivity and that color pattern that I was talking about. They're affected by cold environment. So if I was outside and it's cold outside, I didn't have a hat on and came inside, my head's still going to be cold. My skin temperature is still going to be cold. One of the guys I worked with previously, I was talking to him during COVID. They were checking everybody's temperature every day when the hospital that he worked at. And he came in and he always wears a beanie on his head. So he came in and he stood there and said, "Take off your hat." And he took his hat off. "Oh, you have a temperature. You have to go home." They didn't think that, he just took his beanie off his head and his head is hot. And it was kind of a user error, I guess, but he got sent home for the day and got a free day off from work. But hats and sunshine I put on there can affect, and cold temperatures can affect that skin measurement a lot. So that's body temperature. And then this is a thermometer, and you can see there's a crack there. That's from dropping it, I'm guessing. And then you can see the lens on here. This lens is fairly clean. This is one I had at my desk that I think I might have actually cleaned it. It was kind of dirty, but you could see like surrounding there was a little dirty. But that's the part that when that gets dirty, it usually reads too low, is the temperature reads too low. And it's usually easily cleaned by I use sometimes alcohol to clean it, but I usually wipe the alcohol off with like a water and just a cotton swab or Q-tip and wipe that off and dry it all, because the alcohol leaves a little bit of a residue on that lens, and you want to get rid of that residue with using the water. And don't use anything real abrasive on there. Like a paper towel sometimes can be too abrasive and maybe scratch the lens. Something soft like a cotton swab. And I still can't remember the name of this. Does anybody know the name of the thermometer?
Oh.
The brand? Exergen, that's it. Oh, I couldn't think of it. That's a brand name. So, but this is a temporal. So it goes across forehead and then behind the ear, and then they let off the trigger and it reads the temperature. One thing I wanted to say too, they say, the Exergen people say that this plastic piece here is antibacterial, so it doesn't get bacteria on it. So they usually don't run them with a cover on the top. They just run it like that. The next vital sign is pulse rate or heart rate. I'm gonna go back one slide and I'm gonna make you guys guess. What's the difference between pulse rate and heart rate? Do you think there's a difference? Or is it the same? Different? You're close. You're very close. You're both very close. I didn't know this until I started studying for this. I just always thought they were the same. It can be taken manually by hand, just doing your pulse rate on your wrist with the timer, same as we talked about the respiratory rate. It uses the pulse one, like a pulse oximeter, uses an optical sensor. This is called photoplethysmography, which is my new favorite word that I just learned when I was doing this, and I have a definition on it in just a minute we'll talk about, but photoplethysmography. I can't say that too many times very fast because I can barely say it once. The heart rate is the times the heartbeats per minute, like an electrical conductivity, whereas the pulse rate is the times per minute the arteries expand because of the heart beating. So the pulse is, last week, I was in one of the ICUs that I take care of at work, and I was working on something with the central monitor which we kind of have, they're called overview monitors, and they kind of watch just a couple beds. And we have these alcoves where they're at, and there's a desk there. And I was working on rebooting and loading some patches on that monitor. And I was just in the service mode, and I went back, I changed it back into regular monitoring mode when they were, the doctors were doing rounds. And I kind of got trapped there when they were doing rounds because they were kind of all surrounding me in the hallway, and I was at the desk. So I just sat there and kind of listened to what they were talking about and put the monitor back on regular mode so they could see what was going on with the patient. But I thought this is a good time to study that pulse rate versus heart rate thing that I learned about recently. And the pulse rate was based off the pulse oximeter in this case, and the heart rate was based off of ECG leads. And I was watching the pulse rate and the heart rate, and they varied. The patient they were looking at was their heart rate was varying like 2 or 3 beats, 4 beats, maybe within 5 beats up or down. One would change and then the other one would change, and then sometimes they were the same. They kind of had a little bit of a delay time though in between them, which I never really realized before. I always thought that was just one and the same thing. So the pulse rate is just the arteries expanding. That's the part that you can actually feel when you do pulse rate on your wrist, or if you do it on your neck or whatever. And kind of the way like my Apple Watch works too, is by looking at that with an optical sensor. So if you were troubleshooting like a blood pressure machine and it was giving you heart rate on there, what is that? It's actually a pulse rate, not a heart rate, right? So, and same with the pulse oximeter, it's looking at pulse instead of heart. ECG leads look at heart rate. So usually there's no difference between the two. Like I said, there was a little bit of delay time, but it was pretty much the same between the two of them. But it's just 2 different terms and 2 different ways that the body's actually working when you have that. So that was kind of a gotcha moment for me when I was doing this presentation. I thought, oh, they're the same. Why would? Oh, they're slightly actually different. Some meds can make the pulse in the arms harder to detect. This can interfere with pulse rate monitoring and recordings. So sometimes medications, and usually the people that are doing that kind of screening with the vital signs should know like what meds the patient's on and whether they maybe know that it's it could be a little bit off on the reading because of the medications. One of them is blood thinners, because that pulse is not as strong with the blood thinner because the blood's not quite as thick. Photoplethysmography, also known as PPG, which is much easier to say than photoplethysmography, is a non-invasive diagnostic technique that uses light to measure changes in blood volume within the body, playing a crucial role in monitoring heart rate and blood oxygen levels. So they even say heart rate on here, even though it's pulse rate. But that's the definition off of the internet that I got. So troubleshooting pulse rate and heart rate. Is the optical sensor working? That seems like an easy one. You just look at the finger probe on the pulse ox, is it lighting up? So who knows what colors that pulse oximeter has? It has red, obviously. What's the other color? Green is, that's Massimo, they do CO2 with green. That's the rainbow set or whatever that they call it. There's one that you can't see. What's a infrared? You can't see infrared. So it's red and infrared, and I'll talk about that in just a minute, the absorption rate of red and infrared. BP simulator to check pulse rate if the pulse is off the BP. ECG, you see ECG simulator to accurately detect to determine heart rate. So we all know that one, that's an easy one, and we can do it on any lead. It's gonna be the same heart rate off of your ECG sim on any lead with ECG leads. Okay, blood pressure, non-invasive, or also known as NIBP, and I think Philips calls it NBP on their monitors. I think they leave the I out for some reason, because non-invasive is kind of one word, it's a hyphenated word, but you'll see it either way. And NIBP is kind of the normal way of abbreviating that. Blood pressure is the force of blood pushing against the artery walls, like we talked about for the pulse rate, during contraction and relaxing of the heart. Each time the heart contracts, it pumps blood into the arteries. The highest blood pressure, the highest number, is the systolic rate. So that's usually the number on the top, or that is the number on the top of the number, like they'll say 120/80. So the 120 part is the systolic blood pressure, and that's the heart contracting, the ventricles pumping blood to the body is the systolic rate. When the heart relaxes, the blood pressure drops. That's the diastolic rate in the arteries. So the lower number on the blood pressure reading, the 120 is the systolic and the 80 is the diastolic. And I always kind of remember D because it's down on the bottom, or the denominator is how I always remember the diastolic. Blood pressure is expressed as systolic over diastolic, the 120 over 80 that I was talking about, measured in millimeters of mercury. So millimeters of mercury is a very small measurement. I remember back kind of in the old days when I had to replace, this is when I was younger, I had to replace a BP pump on an NIBP. It wasn't pumping up to the right pressure or to high enough pressure to take a blood pressure. The old ones, I haven't seen it as much on the newer BP monitor. Well, I guess I'll take that back. There are a lot of failures on the X3 BP pumps. Those don't pump, they don't pump up to high enough pressure. And I had one that I thought, oh, I'm gonna save this and I'm gonna find a way to hook it up to like a battery or something, use it as a bike pump on my bicycle so I don't have to pump the pump. And so I went on a conversion chart and I looked up like millimeters of mercury to PSI because my tires had to have like 30, 40 PSI in them. And I found out that 300 millimeters was only about 5 PSI. And I threw the pump away. Like, I'm not gonna be able to use that thing. It's no good for what I wanna do. It'd probably take forever to fill a bicycle tire with that pump. But so it's a very low pressure that it's pumping up to. But it occludes the blood pressure. It occludes the blood going to the lower arm. So it's stopping that blood flow. And then as the pressure on the cuff goes down, the pressure in the arm overcomes the pressure on the cuff. And that's when you start getting a sound that's called a Karat-Cough sound, which I'm not going to get into how in depth on that, but that's the systolic blood pressure, the first sound heard. And then the last sound heard is the diastolic blood pressure. So in troubleshooting blood pressure, cuff size is important. Cuff size, and this is probably one of the most common errors in blood pressure. And you'll see I have a whole page on errors in just a minute that some of them I had no idea about, but hopefully the clinicians know this, but a lot of time I think maybe they don't. So too large of a cuff can result in lower than normal blood pressures, and too small of a cuff, which is what I see more commonly, can result in too high of a blood pressure. Not one size fits all. So if you go to a clinic and they say our blood pressures are reading too high or too low, ask what cuffs are you using? And if they pull out one cuff, they say, we use this cuff on everybody, that's the wrong answer. So you need to have different size cuffs for different size patients. And I have a picture in just a minute, we'll look at that. So blood pressure troubleshooting, other problems, leaks in the tubing, leaks in the O-rings or the cuffs, any of those can leak. What happens when that leaks is that the blood pressure, the pump just keeps pumping and inflating and it won't stop, and usually you'll get an error. I was just working on it was a V100 and I want to say it was error E83 maybe, I don't remember, but some kind of error popped up and I looked it up in the book and oh, it has a leak somewhere. We use these adapters that go from, we use Medline cuffs, which you'll see a picture in just a minute. Where I work at, we use Medline cuffs. So we have an adapter that adapts the two into one because the Medline cuff is one connector. And that seems like that lure connector there is the one that the metal part seems like it always goes bad. That's like one of the #1 things that we replace when there's this error that keeps pumping. The other part, if it keeps pumping, is that bad pump motor like I was talking about. That pump motor doesn't put out enough millimeters of mercury to pump up to the pressure that it's supposed to stop at and then start coming back down. Occluded tubing or kink tubing can go to an overpressure situation where it pumps up and it just stops right away and gives like an error telling it's overpressure. Patient problems, heart arrhythmia is one that can result in a erroneous or it hunting for that pulse. It never really gets the right blood pressure. Use a BP simulator to help troubleshoot. This problem here, this summer was a bad summer for me. I have AFib. It's atrial fibrillation. So my top of my heart goes fast and crazy. It has a crazy beat sometimes. I've had 2 ablation procedures over the summer, but part of it was kind of a learning curve for me. I went in to get cardioverted, which is shock with a defib on sync mode. And they were taking my blood pressure and couldn't find my blood pressure. I'm like, what the heck is going on? You know, usually my blood pressure is easy to get. My heart rate was not normal. It was bump, 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 bump. You know, it wasn't the same. It wasn't a rhythm. It was, that's part of what AFib is. So it kept hunting because my heart rate was so erratic that it couldn't take my blood pressure. And I kind of like made a little note to myself, wow, that's something good to know. And that's actually what this is talking about right here. And usually they can look on the monitor, which is what they did in my case, and they saw to the ECG trace, like that's why the blood pressure is not working, because your heart's such an erratic rhythm that it's not working the way it should normally work. And usually the staff will know this. That's my foot there. This is a cuff, normal cuff. So see this index line right here? This part should fold around like this. I kind of put this at an angle so it wasn't, so you could see this part, but that line there should fall within this white line right here, this range. This is kind of the bigger part is where it's better at. This says use larger cuff and that says use smaller cuff, and that if it's in that white, so if it's in the fatter range of that, it's the right size cuff. If it's outside of that range, it's the wrong size cuff. That means go to a smaller or bigger cuff. The other part in this picture you can see is right there. That says artery line. That should be over the brachial artery, which is, every time I cover this, it makes it really, which is where they usually draw your blood at, is the brachial artery. That you can probably feel it in your arm if you feel down there on the inside of your elbow. That's the brachial artery, and that's where that artery piece should be on the blood pressure cuff. This is a page that I got from Welch Allyn, and I got this after I did this presentation at with the BioMed Association in Colorado. One of the BioMed members sent me this, and I have a reference page on the end. You'll see that there's another page to this. There's a bunch of studies, but accurate blood pressure tips: use the proper size cuff. 2 cuff sizes fit. Use the larger one. Place on a bare arm, so no clothing is supposed to be on there. Place the artery marker over the brachial artery, which was this one that I was talking about here. Apply the cuff snugly, allowing room for no more than 2 fingers underneath the cuff. So when it's fairly tight without any air being in it already, only 2 fingers spacing under there. Have the patient sit quietly for a few minutes. Do not talk to the patient while taking a blood pressure. This is for clinicians, not for us as much as biomeds. But I can tell you, and probably everyone in this room that's ever had their blood pressure taken, not all people follow this procedure. So it might lead to like little erroneous blood pressure reading. Support the patient's back and feet, keeping legs uncrossed. So no crossed legs. You'll see in a minute, I have all the variables. The variable part is the part that I said was all new information to me, or somewhat new information. Keep the upper arm at heart level with the lower arm passively supported. Example is resting on the patient's lap. Keep the arm still during measurement, so no movement. If any movement's gonna, maybe since it's listening, like listening for that sound of the pressure, it could be misinterpreted as that Karat cough sound that I was talking about. This is the one that kind of was interesting to me. You see all these numbers on here. It refers to a page on the very end that I have. These are all the studies that are done in this, but this is blood pressure variability. The following activities affect blood pressure reading. So these activities can lead to lower or higher, in a lot of cases, erroneous blood pressure readings. Cuff too small, 10 to 40 millimeters higher is the cuff too small. 40 millimeters is a lot. Even 10 is a lot. And especially now they say anything over 120 over 80 is considered high blood pressure. So if you're 121 over 80, that's considered high, and they want it lower than that. That's kind of the new standards of blood pressure. It used to be 130 over 90 was kind of the cutoff for high blood pressure. And I think it's still like, once it gets in that range, that's when they start being more concerned. So with the variable of 40 millimeters, that can change your blood pressure reading quite a bit. Cuff over clothing, 10 to 40, higher or lower. So it's got a lot of variability if it's over clothing. So it should be a bare arm that cuff is on. Back and feet unsupported, 5 to 15 millimeters. And this should be posted on TechNation TV if you guys want any of this information. And I think you can probably find this if you search Welch-Allen blood pressure variability. It's a Welch-Allen like white paper that this is from. Legs crossed, 5 to 8. Not resting for 3 to 5 minutes. How many times have you had your blood pressure taken? They walk you back to the room and then they say, sit down, and they take your blood pressure. You haven't been resting for 3 to 5 minutes. And no talking to the patient, which I know that happens a lot. Talking can be 10 to 15 millimeters higher. Labored breathing causes a little higher blood pressure. Full bladder, which means like the patient needs to go to the bathroom before they get their blood pressure taken. Sit down for 3 to 5 minutes and no talking. That's a lot of stuff to have to have correctly, or it can affect this blood pressure reading. And that's when we get called in as, oh, it's not working correctly, and we put it on our sim and it works right every time. And it's more or less one of these problems, I guarantee you. So pain can result in a higher blood pressure, just because when you're in pain, you're kind of tensing up a lot and maybe, real tense, and that can lead to a higher blood pressure. Arm below heart level makes a little bit of difference. Arm above heart level, again, makes a little bit difference. And this one's lower instead of higher. The arm above heart level, it results in a lower blood pressure. Pulse, next vital sign is pulse oximeter. And this is when I was asking the different wavelengths, the red and the infrared. So it's a non-invasive way to measure hemoglobin. It uses my favorite word, PPG, photoplethysmography. Looks for the pulse of the arterial blood, emits 2 different LED lights, red and infrared. The infrared light, oxygenated blood absorbs more of the infrared, and deoxygenated blood absorbs more of the red light. So there's a lot of variables in pulse oximeters too, kind of like blood pressure, but not quite as many as blood pressure. The ratio of absorption equals the oxygen saturation, or O2 sat. It's in a percentage. This percentage refers to how much oxygen is carried by hemoglobin in a molecule. What is hemoglobin? What color is it? Red blood cell? Yeah, red blood cell is hemoglobin. So hemoglobin carries oxygen to the cells. Without oxygen, the body can't live. So normal range is 94 to 100. You guys are from Denver also. What do you see on your pulse ox when you measure it? 95? 97? Wow, that's good. Mine's normally around 94, maybe 93. Yeah, 93, 90. Higher elevation, so we don't absorb as much oxygen in Denver. When I used to live at sea level when I was in the military. I lived in California. I was a biomed in the military, and mine was always around, now I was younger then too, but around 98 or so, 97, 98. But ever since I've been in Denver, like 94 is pretty standard what I read on mine when I check myself. Sometimes I use myself as a test dummy, like everybody probably does. Oxygen saturation, one hemoglobin molecule can carry up to 4 oxygen molecules. So an example is if one hemoglobin molecule is carrying 3 O2, then the O2 saturation, oxygen is O2, is 75%. So we're measuring more than one at a time, so it's several together. So it's we get that 90-something%, 94 to 100, and we said it was normal. Pulse oximeter troubleshooting. There's a lot of different variables to this one too. Movement is probably the biggest one. I don't care even if you have Masimo pulse oximeter, it still gets some noise artifact in there, and that artifact can lead to an erroneous reading. Ambient light. What do you think could affect that ambient light? What kind of light would that be? Very bright light? Where would you find very bright light in the hospital? OR. Yeah, good one. So that OR light is very bright. A lot of the time they'll cover the patient's hand with some kind of drape or some kind of towel or something to keep the light, that OR light, from hitting the sensor on the pulse ox and giving an erroneous reading. Cold extremity, that hypothermia that we talked about earlier, that low, anything below 35. What happens to your body when it's cold? What happens to the blood flow? Goes more into the core, right? Stay not as much in the extremities, more in the core. Tries to keep the core warm. That's how people get frostbite, so on, is not as much like freezing on their arm and no blood flow to those extremities. So it can read erroneously if the patient's real cold. Everyone that's worked in biomed very long has probably seen this one. Non-invasive blood pressure cuff on the same side as the pulse oximeter's on. So if I have the cuff on my left arm and have the sensor on my left finger, when the cuff pumps up, it stops that blood flow. So it's going to intermittently read bad, right? Every time it inflates, it's going to read bad. So that's maybe one that you almost have to see to, like, to say you're doing it wrong, or it's, an operator error. And usually, like, nursing people catch themselves. I actually saw this happen before on my wife when she was in the hospital, and the nurse said something about, like, oh, I don't know why the blood pressure's, or why the pulse ox is dropping out. And I try not to say anything, being a biomed person, because I try to learn from whenever my wife or myself are in the hospital, and kind of look at what's going on just to learn. But then she said, oh, I know why it's doing, I got this on the same finger as the blood pressure. She realized that it was like something that she screwed up. Diaphoresis, does anybody know what that is? That's excessive sweating. So very sweaty fingers where the pulse ox probe is at. And then of course, patient clutching or making a fist, that's gonna change the blood pressure reading, or not blood pressure, pulse oximeter reading, sorry. I might have said blood pressure on the last one. Pulse oximeter reading, making a fist, kind of goes along with this movement thing, is the fist thing. And then another big one is fingernail polish, because the absorption of those two different wavelengths of light can be affected by that, the color of the fingernail polish. So those are big variables with troubleshooting pulse oximetry. Oxygen saturation, pulse oximeter troubleshooting. The probe doesn't light up. That's an easy one. That's an easy one to look at. You just look at it and see if it's lit up. Easy to see that. The cable, if it doesn't light, then check the cable, meaning the trunk cable. There's like a patient short cable, and then there's the trunk cable, the longer cable. Best to use a SpO2 simulator to know if you're getting you're getting a good reference for that. Like I said, I check it on my finger, but I kind of know my finger is pretty good usually. I mean, I know what my range is, around 94. So usually, like, I can use my finger, but if you're really questioning it, I always use a patient simulator. When I gave the presentation, the guys that sent me the Welch Allen thing, they go to a lot of clinics, and they use reusable finger probes at the clinics. And they told me they've seen the reusable probes being, the sensor's dirty, so it's not absorbing that light in there correctly. So cleaning the sensor can lead to better pulse oximetry readings, which for me, I work in a hospital and we use like the Band-Aid style ones that just peel off, and they change them on the patients fairly often. I think I'm not really used to seeing the reusable ones. We do have clinics, but I don't really work in the clinics. And I didn't talk to my coworkers and ask them, have you ever seen, dirty sensor in the clinics? But the guys that work in the field a lot told me that they've seen it before. So put it in my slideshow. It's one of the additions I had from the Biomed Association people in Colorado that I work with. So I have on here fluid/water story time for me. I used to work in a burn ICU. In the burn ICU, they have a tub room, and they take these patients into the tub room, and they wash the patients, and they debride their skin, take the bad skin off, and kind of so they can heal. I had this pulse oximeter probe that I was checking it out, and every time I kept getting SPO2 malfunction. It was on a Philips monitor on an X3. SPO2 malfunction, I'd unplug it, restart the monitor, wait for everything to come up, plug in that cable, went immediate to SPO2 malfunction. Like, man, what's going on with this thing? It's a bad cable. You know, I think it didn't have a sensor on it. I didn't even have the sensor plugged in. So I called Philips tech support. I said, you know, like, having problems with this cable. You know, I don't know if it's a bad lot number or what it is. And, oh, that sounds interesting. We'll send out a field service engineer. Wow, okay, cool, you know. So I put the cable aside at my desk, waited for the field service engineer. He came out 2-3 days later. You're like, oh, I heard you have a bad cable. You know, let's check it out. You know, oh, you know, I'm so smart. You know, I figured this all out. You know, and I figured out it's bad. Philips didn't even know about this. You know, I'm such a smart dude here. You know, and so I watch this, plug it in. It worked perfectly. Oh man, I feel like such an idiot now. You know, like I got this guy coming out to check this cable and look at this, and it's working fine. After a period of time, I figured out when they were using the tub room, where the cable connects, the patient cable connects to the trunk cable, they were dunking it under water. It was getting wet, and the cable inside was getting wet. Even when the sensor wasn't plugged into it, the cable inside, because those are like the female side that it was going in there. And when I looked at it closely, on the end of the cable, this is a different kind of connector than we have now. The new ones, I can't see inside as much, but it had like a D-shaped connector, like a 9-pin, like a DB9 connector. And it was kind of had like a green color on the white cable, like green water and copper makes it green kind of, that like, oh, they're getting the cable wet. You know, and no one ever admitted to it, getting the cable wet or dunking it under water. And so then I started asking questions of the unit, like, when do you guys have these plugged in when you take the patient in there, and does it ever get wet? And does the, oh yeah, you know, we just take it out back out of the water, you know, and that we've been having a lot of problems with our pulse oximeter cables, you know, and I'm like, look, that's it. The cable that I had at my desk sat there long enough that by the time the Philips guy got there to look at it, when I thought I was so smart, it dried out over that time and it worked fine. So I found out that if I waited long enough, the cable would work fine. But I also found out that if I put those cables back in use, a lot of the time, if it barely got wet again, it would fail right away. So I told them, you know, like, I don't think it's the best idea to reuse these once they've had that problem on the cable. And we went through like a whole thing of, Dave, can you find a way to make it waterproof? And can we put like a seal on there, or put like, maybe we were looking at like doing a little floaty on the thing that they could clip a floaty on it, you know, and like make it float on the water. And they even called like the Massimo people and asked them, you know, like, do you have any waterproof cables? And the answer was no on all of it. None of it really worked. I didn't really try to make a seal on it or anything. That might be your invention, you know, like I said this morning, you guys have heard this story that we're here this morning. I already told it, same story this morning. I reused the same story because it's such a good story. But I ended up feeling like a dummy, you know, having the Philips guys come out, and it didn't have that problem, but it ended up like looking at stuff further down. This morning I talked about find out what the whys are. That's what I was talking about, why it happened. And that's really what it was. This is the reference sheet. All those numbers that were on that page. This is Welch Allen, where that page came from. All these numbers are different studies that were referenced on that previous page with the variability of the blood pressure and vital signs to BMETs. Any questions? What do you guys think? Learn anything new? Hopefully, some old stuff that you like remember from along, like happens all the time. You go, yep, seen that one before. Yep, seen that one before. But anyone that hasn't worked in biomed a lot, it's definitely stuff that you'll see a lot. And if you're new to the field and just learning this, you'll definitely run across some of those that I've pointed out today. So, no questions from anybody? Or, yeah, sure. Uh-huh.
But you know, that her skin and the fluids were just not there, and her fingers were so shriveled they couldn't read at all.
Wow.
So it's like we're trying all sorts of different cables, and we read that one. I think it was the chart and realized that her finger was her.
Yeah, yeah. So usually the last part is the patient that they think. when I worked at the Children's Hospital, we did finger pulse ox, foot pulse ox that could tell the perfusion between extremities, like high and low, like usually the patient was laying, but it told perfusion on the legs, perfusion on the hands, but also a forehead sensor we had too, to sense, because sometimes their fingers and that were so small that they couldn't read. So that's, I mean, maybe it's, usually you don't have a forehead sensor though. That's not a common thing unless you work in a very specialized, like Children's Hospital, like I did. That was in the NICU that they had that forehead sensor. The newborn ICU is the NICU. Yours, you said NICU or MICU? Medical ICU. Usually, our medical ICU is usually, I say, trying to be nice about it, but that's where people go to die, usually in our medical ICU. People check in, but they don't check out, or they get rolled out. And usually in the medical ICU, that's usually the worst, like the most sickest patients in the hospital is that medical ICU. If those of you that haven't been around hospitals that much and maybe worked in ICUs that much. I know ICUs can be very intimidating when you're new in biomed, and I still get intimidated sometimes now going in some of the ICUs, that all the crazy stuff going on and all this, they have millions of, well, maybe not millions, but lots of stuff hooked up to those patients. And sometimes it's hard to just get around the room because there's so many things hooked up to the patient. But that's interesting. Makes sense, I guess, right? But yeah, I've never seen that before. I wonder if they use the Band-Aid type or they use the reusable type of probe. Because I think the Band-Aid one, if you're, yeah. If you have the Band-Aid type, if their skin is really messed up, you peel it off and all their skin comes off with it. It could anyways. Oh. I've seen so many bad, the trunk cable part, that's the part that goes from the box to the connector that goes out to the patient. I call that the trunk cable. I've seen so many bad of those. I carry in my cart, I carry a good cable and a good known sensor, so I can always swap my cable in to tell if their cable is bad, because the story always is, we just replaced that cable. And I'm like, well, the one you replaced it, is that a good working cable or not? You know, I don't know where they got it from, or if it came out of the box or it just came from another patient room. And what I found a lot of the time is they'll switch between rooms, and that bad cable, then they'll end up having like all these different boxes. They're, oh, it's not taking blood pressure. Then I'll get another box. It's not taking blood pressure. It's not, or not taking pulse ox. Pulse ox isn't working. Pulse ox isn't, and it kind of follows the cable because they're just switching that cable from room to room. Like, it's a cable problem. We got to find the cable that's bad. We can't just keep putting this same cable on the next box and thinking it's going to work. It follows that cable a lot of the time. So that I have a good known cable. I actually have, we kind of switched our cables to a different type of Massimo sensor. So when we switched them, I saved the old cable, because it doesn't really matter what I use to test it with. If it's the old cable or a new cable, it still works the same way. It's just the connector is different on the new one. But I save that on my cart to test like monitors like that. And probably a lot of you probably do the same thing, I would guess. You have a known, you always have your known good ones that you trust, and you've tested them maybe on your monitor in the shop, and you tested on your sim, and you know it's working the way it should work, and you can swap those cables in and out. And I think whenever you can do swapping troubleshooting, that's kind of the easiest way to get the right answer. If you have known good stuff that you can plug in there and see if it's in that part. So good point though. I like that. I like hearing about stories like that. Anybody else? Yeah.
What do you think is the value in the blood pressure cost? Should it be just like one-time use, or?
Oh, the reusable cuffs versus the multi-use cuffs. I think a lot of the time, reusable cuffs are used a lot in clinics, where those, the one-time use cuff, they're not always one-time use, but they're kind of assigned to a patient. So it's that patient's cuff while they're in the hospital. And usually they're latex-free cuff, where a lot of time the reusable ones might have latex, and a lot of patients have latex allergies. And usually it'll say on the cuff latex-free. I don't remember if mine, that I had the picture on here. I know it's back here a little ways.
Store marker clinic ones, I don't know if you've seen those. We have white ones for.
White are the disposable, yeah. See, I don't. Usually somewhere on here it'll say,
Natural rubber latex, or natural
does it say on
rubber
here?
latex.
Oh, not made with natural rubber. So this would be someone with that latex allergy, it should be okay. That's a new, well, kind of a new thing in hospitals. It never used to be a thing when I was first starting in biomed, but now it's pretty big. Even the gloves that they use are latex free now. It's because they figured out a lot of people had latex allergies. But I think that in a clinic setting, reusable cuffs are a lot like that one that I had the picture of. But in a like inpatient setting, like ICU or whatever, usually they have a cuff assigned to that patient and kind of their cuff as long as they're in the hospital, and then they throw it away. And it can be used more than once, even though, if they make you believe it's a throwaway cuff, it can be used more than one time. And those are the ones that I've seen that develop leaks probably more often than those reusable cuffs though. So if you have a pumping problem and that cuff's been there a while on that patient, maybe it needs to be replaced. They seem like they're a little more fragile than those reusable cuffs. Yeah, you're welcome. Anybody else? It's time to, what's that? Level 1 trauma center. Yeah. Same as you guys, I think.
Yeah.
You're the Denver Knife and Gun Club, right? That's what you're known as? That's where like all the patients that have been shot and stabbed and the police go a lot of time to the hospital that those guys work at.
Yeah.
We just have the same thing, but in Aurora, we probably have more, maybe as many or more shootings than